Now I invite Dr. Rekha PS for her talk on pupil, the key for the diagnosis. Dr. Rekha is an assistant professor working in Government Medical College, Mancheri.
So good afternoon all. I'll be talking about pupil, the key for diagnosis. So sudden loss of vision can occur due to various reasons, and proper examination of the pupil will help us to clinch the diagnosis. So why pupil assessment is important? It is important to detect both the efferent as well as the efferent disorders. Efferent disorders, mostly it is due to optic nerve pathology, and efferent disorders, even that also can present as sudden loss of near vision. So systematic examination of pupil is important, starting from the size, shape, position, and reaction. So first we'll see how pupil is important to detect the efferent disorders. So mainly the reactions are important. The most important test will be swinging flashlight test. It is to detect relate to efferent pupillary defect, also known as the Marcus gun pupil. So it mainly helps us to detect the optic pathway dysfunction. One prerequisite is that it requires one normal pupil. But you should keep in mind all lesions beyond the lateral geniculate body will not have RAPD. Why? Because you can see the pupillary fibers separates from the visual pathway before reaching the lateral geniculate body. So how to do the swinging flashlight test? We are comparing the direct light reaction of both the eyes. We swing from one eye to the other, and 2 points we should keep in mind is you have to hold the light source equidistant from both the eyes while swinging from one eye to the other, and also the ideal position will be to shine the torch from below so that we can see the pupil clearly. Another method is a modified up gaze technique where we ask the patient to look up and the light source and the examiner should be in the same line. Now we can grade the related efferent pupillary defect as 4 grades. Grade 1 is the weak initial constriction followed by greater redilatation. Grade 2 is initial stall of movement and greater redilatation. Grade 3 is immediate pupillary dilatation, and grade 4 there is no reaction to light. So in all the 1, 2, 3 grades, the pupil size will be normal. So an isochoria is not a prerequisite to say there is RAPD. We can also quantify RAPD using neutral density filters. Here different densities of filters are placed in front of the normal eye, and then we do a swinging flashlight test. We have to do it, we have to increase the density of the filter till we get till the RAPD disappears. So that is the amount of RAPD in log units. So suppose one pupil is abnormal due to some structural problem, due to some trauma. So what will you do? You have to concentrate on the normal pupil. You have to see that and then do a swinging flashlight test. Here we are comparing the direct light reaction of the normal eye with the indirect light reaction of the eye with the structural deformity. That is known as a reverse RAPD. Now if the direct light response is weak, then definitely we have to look for the near response. Here you should it should be a moderately lit room, and you should use an accommodative target. We should not use a light source. And suppose the near response is more than light response, then we call it a light near dissociation. We have a different set of conditions leading to light near dissociation, and we have to investigate in that area. Now next is the assessment of pupil size. So pupil size, if the difference of more than 2 millimeter, we call it a pathological anisocoria. Usually it is pathological if the size is more than, difference of size is more than 2 millimeter. So if such anisocoria is there, then we have to see whether the anisocoria is more in light or dark. So when you shine torch in light, normally the pupil should constrict. So if it is not constricting properly, that means the parasympathetic pathway is at fault. And if the anisocoria is more in dark, that means the sympathetic pathway is at fault. So first we'll see conditions which can cause anisocoria that is more in light. So first things, the commoner things and the conditions which can be easily identified should be ruled out first. So first thing you have to rule out is a third nerve palsy. So you have to check for the extraocular motility and also the presence of ptosis. Sometimes it may be a mild ptosis and the restriction of movements may be very minimal, so you have to look for it. The next thing you have to rule out is structural changes. So do a proper slit lamp examination. Ask for history of any prior intraocular surgery or trauma. Look for any signs of inflammation. Look for any iris ischemia like neovascularization, or it can be an acute angle closure glaucoma also. So if both these are ruled out, then look for the, definitely you have to check for the near reflex. and see how the near reflex is there, see the reaction. If it is a tonic response, that is more in favor of a adhesitonic pupil, or if there is no response at all, it can be a pharmacological dilatation, and we can differentiate these two by using a dilute pilocarpine, 0.125 percentage pilocarpine. So if you use pilocarpine, if it's an adhesitonic pupil, it constricts, whereas pharmacological dilatation, there will not be any constriction. So what is adhesitonic pupil? Here the ciliary ganglion is affected. It can be idiopathic, or it can be due to inflammation associated with viral infection. Usually middle-aged females are affected, and more commonly it is unilateral. So these are the other conditions which can present as unilateral tonic pupil. Can be varicella zoster, giant cell arteritis, syphilis, sarcoidosis. And bilateral tonic pupil, you should think of diabetes, alcoholism, syphilis, and dysautonomia. Now suppose the anisocore is more in dark, that is more in favor of a Horner syndrome. So Horner syndrome can present as with litosis. It is due to less sympathetic innervation to the Muller's muscle. And next finding is a meiosis. It is due to less sympathetic innervation to the dilator muscle, and also with facial anhidrosis. Another test to detect Horner syndrome is a dilatation lag. That is, there will be a slow pupillary dilatation in dark. Suppose when you dim the light, there should be a dilatation which is usually immediate, but in Horner syndrome, it will be very slow. Now, there are various pharmacological tests to detect Horner syndrome, starting from the cocaine test to see whether it is normal or Horner syndrome, but these tests are not usually done in our clinical practice. So, whenever you get a doubt of Horner syndrome, or you think it is, you can go ahead with MRI and MRI of head and neck. So, in short, these are the parameters that you should look for. That is the size of the pupil, both in dark and light, the shape, color, reaction to light, the direct, indirect, and the near reflex, and also the dilatation in dark. So, thank you all for your patient hearing.
Thank you, Dr. Rekha. That was a very excellent talk covering A to Z of the pupil.